With 10 years of vast experience in various profiles in human resource management, she has been associated with Palem India for the last 7 years. Her areas of interest include HR management, palliative care, and project management. So, without much delay, I invite Ms. Ardi for the session. And Arti ma'am, over to you.
Thank you, Shri Priya. Good evening, all. As introduced, Sati, working as National Coordinator with the State Facilitation Division. I act as coordinator between Pallium India and the regional coordinators that we have across India. So let me brief about what State Facilitation Division actually works on. We as a division try to take the work that Pallium India does to various regions in India with a vision to facilitate access to palliative care to those those who are in need. Details will follow in later slides. I'll explain you in detail. This session will brief you about how you can, like as Shri Priya already told you, how you can open a palliative care center in your region. You may be already part of some hospitals, or individually you may be having some clinics. We shall guide you on how to start a palliative care service in your setting. Please feel free to clarify queries at any point of time. We'll be happy to help. If in case you're not able to speak or raise your hand, you can just post your query on the chat box. So we'll be reading out the chat box after I complete the session. Or maybe in between, if you feel bored, because we can look into the chat that time also. So so starting, we can start with the session. So let us start with this. This is called the WHO Palliative Care Advocacy Triangle. As per WHO, to set up a successful palliative care center or to organize a palliative care service, we need to ensure three things: education, drug availability, policy, and implementation. So first we'll go with education. So previous slide. Yeah. There are barriers to palliative care which we'll have to overcome, which we'll have to overcome through education, like lack of awareness among the professionals, lack of awareness among the administrators, and lack of awareness among the public. So these are the barriers that we need to overcome through education. So what we are doing right now here is one of those. We are now as a part of giving education about palliative care, we are going through a course, FCPA. So that is part of that. So it is essential to educate the public. The public demand does persuade professionals and administrators to think. So that's what education helps us. Next is drug availability. Pain relief is integral part in palliative care, and for that, availability and accessibility of pain relief drugs is necessary. So morphine, as you all know, is the mainstay of pain management. Its availability has been eased to small extent by the amendment of NDPS Act in 2014, but most of the states are yet to implement them. So that's one part. Now, coming to the policy and its implementation, in much of the world, palliative care came into being because of individual initiatives and action by non-government organizations. However, to achieve national coverage, palliative care needs to be integrated into general healthcare delivery system. So government action is also needed to remove these barriers to access to pain relievers. It is essential for budding services to develop their own policies that can overcome any gap in available facilities. So we can plan when we plan to have a palliative care service, you just have to remember to you should be trained. You should have opioids available, and there should be a policy or a program which will support your service. So you need to keep these three things in mind. before you start thinking of providing palliative care service at your region. So now moving forward, now we'll think more into the Indian context. So palliative care, what does it mean in the Indian context? So first thing, in Indian context, as you can see that we have brought the delivery, the palliative care delivery has been broadly classified into three major categories. One is standalone. So standalone model, we'll go one by one. So standalone model is an independent facility where we provide palliative care with special focus or specific focus on pain and symptom management and improving the quality of life for patients as well as their families. You might have learned through all your sessions that it's not only the patient that we take care of the families as well. So that's also being considered. So this delivery can be done through either a hospice model or a palliative care center. Next, delivery is through a department or a unit within the hospital. So there can be a dedicated department for palliative care attached to a established hospital. So for example, in there are 4 types of association that we can have is when you're working in a government hospital, you can have a separate department specifically for palliative care delivery. If you are working in a charitable organization, with all the services that you can have palliative care services also along with that. Then we have sustainable model, wherein you charge for, reasonably charge for services that you provide. You can have a palliative care department there. And for a for-profit model, entire for-profit model, a hospital wherein you can have a specific unit for palliative care. So these are the 4 types of delivery that happens in a department or a unit within a hospital category. Moving forward, this next is the community-based home care. This is where the community gets involved. Here, we can reach to the care receiver where they are. That's the main agenda or main thought behind community model home care. So here the social capital act as a bridge between the micro and the macro element. So the major element of social capital is volunteers. We'll go through the model in a brief later. So we shall go into, we shall now see what are standalone hospice that we have over in India. Few standalone hospices that we have are these. The first one is Sipla, which we have in Pune. Next is Roma Abedana Hospice, West Bengal, and next is PGI Chandigarh. These are few standalone hospices that we have. Next is few examples of palliative care unit that we have inside a government hospital. This is a government hospital in Nagaland. Next, so coming to the community model. This is the third category that we are talking about, in which palliative care delivery is through community-based home care. The difference between a regular home care service and a community model is the mode of delivery. In Indian context, the macro components here will be the tertiary healthcare institutions, maybe like big healthcare providers, and so the main point is that the macro institutions or the healthcare institutions are getting bigger and bigger, and the micro element, that is a beneficiary, are not able to reach that. So now what the community-based home care or model suggests is that next, this is the bridging that happens between the micro and the macro component. This is where the community concept comes into action, which we call it as a meso component. This is not a structure that is taught anywhere. This is just what we have created for creating an example. That's it. So here the community takes the responsibility or the ownership of bringing the micro and the macro components together, or we call it as bridging the gap in between them. Now, Kerala state has utilized this power of community model, which might not work in the settings where you belong to, but we would like to bring it to you as an example or a prototype with which you can get an idea how you can go forward with setting up a service. So it's just an example that we want to create. Next, coming to the this is a photograph which of Nair, K.N. Nair. He is one of our volunteers. We call him Nair Uncle. So he has been part of Pallium India since, like, he was introduced to us as a to Pallium India as a caregiver for his wife. His wife was our patient and she died in 2004. He is a ex-serviceman. After 2004, he took an initiative to be a volunteer by himself and took the ownership, took the responsibility of the city home care. City home care is a home care that we run inside the city limits. He would know each and every patient that he is seeing. Every day he goes to the city home care with our team of doctors, nurses, and social workers. He'll go and meet patients around the city limits. He knows better than our team. So that's I would take that privilege to tell, because he's the first person to know, or our team reaches to him first to know about the patient, and the patient also reaches to him before reaching to our team. So that's the connection that he has with our patients as well as our team. So he has been not given any responsibilities on paper or anything that you should do this, you should do this. No, he does it for himself. It's for his satisfaction. That's the satisfaction he gets when he see the patient, happy and satisfied by the services that we provide. So that's what that's an example of a volunteer. That's what I want to tell you here. Next, we'll come to the crux of the this session. So we have made a 10-step approach. It's just a basic flow that we'll follow. It's not a concrete rule as such that you should follow these steps to open a, you should follow this flow. It's just a example, just a, flow that we created. It may vary based on your setting where you belong. So you just note down the points that are you need to keep in your mind while opening up a service. So first is of course arranging funds. Before starting to organize the whole program, we need to think of where we can arrange funds from. If you are part of a government hospital, there are funds available with various programs like NPPC and Ayushman Bharat. For private, of course, you can create the service and you can charge for it. It's for the charitable or individuals where the actual challenges for them, we can go for a CSR or a public donation thing. First thing you need to keep in mind is to arrange for the funds that you are, that would be needed for organizing such a service. Next, and which would you be opting for? So if you are a government hospital, you can approach the government fundings. If you are a profit organization, then you don't need to think of anything. You can sell your service and get the money. And if you are an individual or a charitable organization, you need to go for a CSR. Next is having a having a team which is trained. So initially, when you start a palliative care service, the basic unit that you will have to have is a doctor, a nurse, and a social worker who is trained in palliative care. So going forward, as you grow, you may require allied medical professionals like pharmacists, physiotherapists, occupational therapists, etc. But as a basic unit, you would need a doctor, nurse, and a social officer. Keep it in mind that they should be trained in palliative care. The next thing that will come is infrastructure. So for OP, it can be a room that is or a space. And for inpatient unit, you will need furnitures like beds and caregiver coats and everything. In case of home care, you'll need a vehicle which can be used by a team to travel to the needy with the essentials like medicines and other consumables. Next step is to procure opioids. As I mentioned in the starting, that we need to ensure the availability of essential narcotic drugs for pain relief. To procure, store, and dispense opioids, you will need to be a part of recognized medical institutions. It's a lot of information required to understand the topic. I think you have already covered opioid availability session last day, so you might know what all procedures are involved in the opioid procurement, storage, and dispensing thing. Next, what you need to understand is network building and establishing contacts. So establishing contacts or connects. Here, you will need to establish connects with the existing experts in palliative care nearby your area. And this will help you to understand the local challenges and the support available. So those palliative care centers which are already established, they'll know the challenge that they had faced while opening up such a service, and they can also they can also provide with the support that they would have needed when they started. So you will get a mentoring thing from them. Next is you need to create awareness for public as well as the team, as well as your team, to help them know about more about palliative care. So this will help you to get referrals as well as identify local champions who can take your work to more people. So awareness will help you likewise. And next, we'll go one by one for OP, IP, and home care, what all things you need. For developing an OP, maybe you can have a local hall or a conference room or a classrooms of schools or colleges that you have nearby. Or a room if you have if you are already part of an hospital. So you just need to ensure that you have that's all the facilities that you find are disabled friendly. That you need to make sure that whichever facility you are finding out should be a disabled friendly space. And inside the OP, you can have a examination table, a chair, some basic furnitures, and essential medical equipments for conducting a outpatient clinic. And so that you need to ensure. And if you are planning to dispense opioids there, you need to have a double locking system. You might have studied that in the opioid availability session. You need to have a double locking system to store opioids. Next is developing an IP. In IP, you will need a little more infrastructure in terms of beds for patients, side lockers, etc. You'll know better than me what all things you need in an inpatient unit. Next is for home care. As I already mentioned earlier, that you need a vehicle which can accommodate the basic unit. The basic unit means a doctor, a nurse, and a social officer, and medicine and consumables that you'll need to take care of the patient needs. There are scenarios, and we have seen such scenarios wherein a doctor will go in a bike with a bag of medicines and go for home care. So it's just a passion that drives. So you don't need more vehicles, a big vehicle, small vehicle, 2-seater, 3-seater. No, just a scooter will be enough for you to do home care if you are willing to do. So That's there. Now, I have already mentioned about Nair uncle's involvement in our home care thing. So, you know, the involvement of volunteer as well. You can, while creating awareness within your area, within your region itself, will bring you volunteers in. You'll get volunteers through awareness. So you can involve them too. You should involve them, because alone you can't take this vision forward. Next. So now coming to the strategy for financial delivery models. This will help you. This slide will, I'll be explaining how we support or facilitate palliative care service with already discussed models like government, charitable institutions, profit models, and sustainable models. So now now I'm going to explain how we are going to support you in your dream. So, talking about the capacity building, capacity building is one of the major support that we are providing. We help, doing workshops, orientations, foundation trainings for doctors that we are already doing right now. We have foundation trainings for doctors, nurses, health workers. We do training for faculty for UG curriculum. I think this batch is for those team only. So we do that also. Then we give training and engagement for volunteers, community, and there are specialized training also, like Pali-COVID for training for physiotherapists, training for pulmonologists. And in government, we provide support for training the CHOs, ASHA workers, ANMs, etc. So we do that trainings also. Now for opioid availability, we support in getting the NDPS Act implemented. As I told you earlier, that even though we have that NDPS Act in place, there are states where the implementation has not happened yet. So we will come and talk to the authorities. We create awareness for the medical institutions about RMI process that with the state drug controller. We try working with NHM to get opioids included in the state essential drug list. There is a drug list which is already in place, essential drug list. Morphine, opioids like morphine, etc., are not involved in that state essential drug list in some states. So we work with NHM also for getting that involved in the essential drug list. Each state has separate EDL. Now, we do hand-holding for palliative care units at district level, connecting palliative care networks, and we provide documentation assistance and support. So what all documentations are involved in running a palliative care services? We provide the framework, like we provide the soft copies, and you can make changes based on your regions or based on your hospital format or whatever. Now, developing program implementation plan for state implementation of NPPC, development of palliative care through health and wellness centers are under Ayushman Bharat scheme. Pallium India contributes towards developing a state palliative care policy, where we do have regular connect with Ministry of Family and Health Welfare for developing palliative care in each states. So we have a team working in the central region with central ministry for policy amendments and all. We help in recruiting human resource for palliative care center. We facilitate cost management and sustainability. We help build funds through donations and help in grants and CSR applications. So we have a team here here for resource mobilization, which will help you to find grants, to file CSR applications. So for getting CSR funds, you need to get registered under you need to have a CSR number. So you need to file an application for that. When you get the CSR number, then only you can apply for CSR funds. So our team here will help you do that. So that's how we facilitate getting funds. Now, next is the one thing that we are starting for, we have just started is implementation and monitoring, implementation, monitoring and evaluation. So here we send an implementation team of doctor, nurse, a coordinator to your site, wherever you are planning to, or wherever you are starting a palliative care center, we'll send an implementation team, a basic unit, and we'll stay with you, handhold your team through the process of setting up a palliative care service for a given period of time. We have not started this program, but we are in talks with several stakeholders to start this initiative. Next, next are the challenges that we face in almost all the sectors, like government, sustainable, profit, and charitable institutions. The challenges that we, as in our regional coordinators, face while approaching them for starting a palliative care service is availability of funds. That's in all sectors. Few want to play safe, like procurement of opioids that we have already learned. It may cause few legal, it has few legal implications also. So they don't want to get into those headaches and want to play safe. But we help them understand that if you are maintaining all the documentation and registers that they require, no legal implications will come. If you are maintaining all the records, you don't have to fear of any legal implications. So that's what we help them understand. So we likewise we have, since 2021 we have almost 15 institutions have got RMIs, and you are on its process is going on. Almost 10 are in 10-20 are in pipeline. It takes 2 months to get RMI certificate in hand. But the process takes 2 months. So we have since 2021 we have procured 15 RMIs till date. So we were able to convince them, and government hospitals are deemed RMI institutions. They don't need a certificate. They are already eligible to procure and dispense opioids. They just need to maintain the records that are asked by the authorities. So that's what we make them understand. Like, don't worry, you won't fall in for any legal actions if you are maintaining all these records. In government, the major things, you can read all the challenges. If you have any doubts in that, you can ask me. I'll touch upon the main things that we are facing. In government, we face that once we, training an individual takes time. Like, for you, it's a course of 1 month. For on-site training, it's a course of 6 weeks. So 6 weeks, 1 month, all our resources are going into training a person. A person is trained and he or she is about to start a palliative care unit, and the person gets transferred. So now all our efforts for bringing up or opening up a palliative care center is gone downhill. Now once again we have to start again from the scratch, like training the individual, getting the RMI in his or her name. So that's only a recognized medical physician can apply for a recognized for an RMI. So again, we have to train another person. Then again, he has to apply for RMI, and then again, he will start the operations. So again, 3 months gone. So that's what we face in government. And there are issues to convince people also, like the hierarchies. Some people are like, no, I won't sign. If he is signing, I won't sign. If you are approaching him, then better go and approach him. I won't support. So these are the things that my team faces here. So that's the challenges that we have. If you have any doubts, just let me know. These presentations will be shared with you. Next. We can move forward. So this is a standard audit tool. This is used for palliative care programs across India. You can use it for your organization as well. This will help you to understand where you stand. Like this is a kind of self-evaluation audit tool to know where you are standing. And here you can see two parts. One is essential and one is desirable. Essential are the minimum requirement that a center should abide, and the ones listed in the desirable are regular requirements. The link for the original document is given below, like in the footer. You can click on the link and then go to the original document. It's these are just the screenshots, so you might not be able to see the things written there. It's just a basic tool. It's self-explanatory. You can download it at your end when this PPT is shared with you. Now, coming to the Pallium India model, this is called DEF model: demonstrate, educate, and facilitate. So we'll go one by one. First one, we'll be looking into the demonstration model. The demonstration model, as you can see here, is Trivandrum Institute of Palliative Science. This is the palliative care center that we run here. Then we have the link centers or OPDs in hospitals. Then we have home care. So link centers are, I'll explain you in detail what does link centers mean. As I mentioned earlier, that awareness creation is one of the major thing that we need to do before before starting or after starting. Whenever you go into the we go and create awareness in the community. And in the community, while creating awareness, community in the sense it can be a group of people who some association people, or maybe some schools or some clubs like Rotary clubs, Lion clubs, and etc. So, like a people of similar group, or maybe a vast group, any type of people, a local public. You take a local public. When we create awareness, when we take classes on palliative care and explain about the volunteering thing, we get like-minded people who are interested to take this initiative of working for a noble cause, and they come together, they come to us and tell that we have people in our region who are very who are who are very needy, who need palliative care. So they do the need assessment in their area. When we are giving the presentation, they feel like, I have seen a person who is suffering, who needs care, who needs palliative care in my area, and nobody is looking after him or her. So these kind of people, those who have similar thoughts, come together and ask us if we are interested into giving services to them. So they form a group. They register themselves as a society, and then they are called link centers. So we have a formal MOU or a terms of engagement with them for maybe a period of 2 to 3 years. And then that's what we do in here, like in Trivandrum. It happens here in Trivandrum. So we have around 14 link centers in Trivandrum, like these small organization. They'll cater to the needs of the needy who are in their region. So for example, we all these 14 link centers have coverage to around 10 to 20 kilometers of their around their region. So they in initial periods, we'll support them with a doctor, nurse, social officer, all kinds of support that a patient requires. And over the time, when the organization is they themselves go and find funds. So the one thing that you need is fund. They create awareness by themselves, bringing in more people. They recruit people. They find a doctor who is trained in palliative care, or they get us for training them, and they become a small palliative care unit. And when we feel that they are sustainable enough to run the center, we withdraw our support and then we find somebody else. Like, so that's how the link center thing works. So likewise, we have 14 link center running right now, and already sustained link centers are around 3 to 5 who are already sustained. Like we started our operations in 2003. Like our trust was formed in 2003, and we started the organization or giving out services in 2006. Like we started in Trivandrum in 2006. So until then, like it has been 18 years. Until now, we were able to sustain 3 to 5 link centers which are running by themselves right now without our support, without our any support. So for any further support, like if the doctor and the team needs some advice on palliative care on any symptom management, they can always come back to us. We will be there, but now those centers are running by themselves. So now I'll show, this is the, this is the palliative care delivery that we do here. We have inpatient unit, which is a 16 bedded facility. We have outpatient care in government hospitals as well as these link centers. So we run OP in the Medical College Trivandrum, and we have we have OP in the we have a pediatric palliative care OP in a government hospital attached to the medical college itself. It's called SCT. Then then we have outpatient care units in the community health centers, PHCs and CHCs, at different attached to the link centers. So we have outpatient units like that also. We run home care in and around 35 kilometers around Trivandrum. We don't have any other centers, like we don't have another Pallium India anywhere else. It's just one. We have link centers everywhere, and we have district initiatives in each district, but those are not run by Pallium India. Those are those are organizations that have come by themselves. It's not, we might have, worked with them for the catalyzation of these centers or initiatives, but it's not run by Pallium India. Everything is done by themselves only. The link center which are under our support, those are under our support, but those are sustainable. We are not supporting them with any other funds or something like that. Another thing that we do here is rehabilitation. Rehabilitation in the sense like many types of rehabilitation happen. One is education. We give out education support. We give out food kits for patients who are not able to have, I'll tell you how this food kit concept came in. Like whenever you give prescribe medicines to patients, you are used to tell them that take this medicine after food, take this medicine before food, take this medicine after food. And likewise, in the initial period, before we introduced food kit, one of our patient came in for the next review, taking all the medicines with him. And when we asked him, why didn't you have these medicines? He told that you told to have it after food. I don't have food to eat, so I didn't take my medicine. So that's how the food kit concept came into our mind. And if you are telling that you have to have medicines after food, you are bound to give food also. So every first week of every month, we provide a ration kit to them based on the diet that they, the patient is supposed to have. Based on that, we have kits. Now we have named kits from A, B, C. So now it's K kit that's running. So every patient with, specific requirements, we give a separate kit. So now we have A, B, C, D up to K. We have K kit. So I think in a month we give around 100 food kits, 100 patients, 140, 150, something around like we are providing kits. Next is community participations. I have already mentioned about the link centers. So those are solely, there's a wholly run by community volunteers. We are not, Palm India don't have any ownership on that. Next is Halfway Home. Halfway Home is something that we run here at Palm India. This is a initiative that was initially supported by Social Justice Department, Kerala, Government of Kerala. They supported us for rehab. It was mainly done for the rehabilitation of paraplegic patients. So those who are on wheelchair patients. So here, what happens is we have patients who get admitted at Halfway Home. They are trained on how to live their life independently without depending on any others. They have been living like that only, before getting on wheelchair, they have been living like that. So after that also, we are training them on how to be independent. So we train them to get on the wheelchair and to the bed through by themselves. So we have a goal of admission. Anybody who comes in will have a goal of admission, will be training, will be vocational rehabilitation, anything based on the assessment that our social officers will do. So based on that, we'll have a goal of admission, and then while they are here, they all the area, the Halfway Home area is disabled friendly. The doors and everything are widened so that a wheelchair can go by itself, like they can roll in the wheelchair by themselves, no hindrance will be there. The washrooms and all are wheelchair disabled friendly, so they can get down and get move freely. Nobody else have to be there for to take care of them. We do have a caregiver, we'll have a caregiver with them, but we'll help them, we'll train them how to move freely by themselves, and we'll help them learn a vocational training also through which they can earn. So we have trained them to make umbrellas, to make lotions, soaps, paper pen, most of the things that they can do by themselves being on a wheelchair. So we have trained them as chefs also. So we have a few patients who are who are trained trained by the Hotel Management Institute here. So they are now making small snacks which they can do by themselves, and they sell it and earn their living. So that's how they work. We'll ask them what is your area of interest, and then we'll teach them. And now few of our patients are trainers also. So now they train others patients. So that's how. So that's one of their earning, another earning, what you call way. So they can sell their items as well, and they can be a trainee as well, trainer as well. So that's how they earn. So and we have a small rehab store at Pallium India, which will help them market their products. And who all are visiting us will also have a we'll also see all these items, and if they are interested, they can put their order directly with the patient. So that's how that also happens here. So when you have time, or when you feel, you can come to Pallium India to pay a visit. You will see the Halfway Home and all the, you can have a look how Pallium India works here. So till date, we have touched 21 lives since last 16 years of service. And through community engagement, we have 87 volunteers and 14 link centers that we have already talked about. Next, just took most time. So this is a national helpline. You may note the number. Whenever you feel like you have any concerns, like as a professional, you can call us for any advice on pain and symptom management. And as a patient, also we get calls for same pain and symptom and for palliative care needs. So you can have this number and also share with any of your contacts who may need palliative care. We have this in Malayalam, English, Tamil, and Hindi languages. We operate from Monday to Saturday, 9:30 to 4. This is a recording, voice recording. This runs like that. We'll record the voice and then we'll get back. So you can drop in your message anytime you call us. It's not like limited. So we'll be calling back at these times, but you can send in messages anytime. Next. So moving on to the education part. These are the training programs that we have here for doctors, FCPM, FCPM and CCPM. CCPM is this 6 weeks course that we run here, residential course. You have to come at Pallium India to undergo this course. It's a 6 weeks course. It's same only. One is foundation. What you are doing here is foundation, and when you come here, it will be certificate course, full-time course. Right? Next is nurses, FCPN, CCPN, same. Then we have allied healthcare professionals who undergo FCPC. Then volunteer for voluntary training program, it will be ETP. For student volunteers, we have we have collaboration with university. So Kerala universities. All these colleges under Kerala University are required to train their students on palliative care. So we do that also. The palliative care beneficiaries who are palliative care beneficiaries, for them also we have sessions called Arohan and specialist trainings like RCPM, refresher course in palliative medicine. So after doing FCPM and getting more, after doing palliative care for a few years or so, then you can come and do the RCPM, right? Next, facilitate. Okay, this is where our team comes into picture. The philosophy of facility division is to integrate palliative care into 3 levels of healthcare: it's primary, secondary, and tertiary. So first, I'll show you how our regions are divided. We have North region, Northeast, Central, and South. North region, these are the states that come under North. If you belong to any of these states, you will have to coordinate with Rajendra. Rajendra is one of our regional coordinators. He will, for any palliative care services query, you can get in touch with Rajendra for the North region. For Northeast region, it's Rontu Sangma. For Central, it's Sunanda, and for South, it's me. You can get in touch with me. The numbers of these regional coordinators will be shared with you either through WhatsApp or through the chat here. So anytime if you want, if you based on your query, you can based on your okay, in the chat you have got the number of South regional coordinator as Vishnu. He was taking care of South region, but now he's not. He's not with us right now. I am coordinating the South region. So any person who are from South, you can get in touch with me. My number will also be shared here for any question. Irrespective of any area, if you want to, if you have any queries, you can get in touch with me, no problem, because I'm right now looking in, I'm the national coordinator and looking into the South region as well. Any queries, you can get in touch with me. Now, you can go, yeah. Okay, now I'll explain you about the philosophy of State Facilitation Division. These are the 5 objectives that State Facilitation Division has is catalyzing new palliative care centers and services. We help in end-to-end facilitation for catalyzing centers, starting from the scratch to inauguration, till inauguration. And after that also. Then we assist in opioid accessibility by facilitating in getting RMIs, getting certified as RMI institute. It's a very long procedure. You might have learned it, and which will we help our stakeholders to go through each documentation, like filling out application, talking to the drug controller, maintaining the records, how to maintain the records. All the samples will be shared by our regional coordinators. So we'll facilitate in you and maintaining all those records as well. Then we enable palliative care learning in medical institutes. As we all know that education plays a major role in delivering palliative care. We try to work with medical institutes to involve palliative care in their undergraduate curriculum for doctors. Here we work with trainers where they train the students in palliative care. So now moving forward, you all will be training your students in your institute. So, that program is called Faculty Development Program. That's what we are. After this FCPM, you will be into Faculty Development Programs. So, next is we work with stakeholders to help them build community engagement and help them mobilize volunteers. So here in Pallium India, we create awareness among the public, get similar interest people work together, and then they form groups as links. And as I already mentioned, they take the major thing that a community engagement has is that they take the ownership of taking palliative care across their region. It's not Pallium India taking the responsibility, or it's not you taking the responsibility. It's the community taking the responsibility of their region. So it's their responsibility to take palliative care across. Next objective that we have is to develop pain-free hospitals. This objective is in a budding state right now, even though we have 2 pain-free hospitals across India. But here, we are not into, major focus have not been started for that. What happens in pain-free hospitals is like, we try to develop a hospital wherein a patient that enters for any treatment is assessed or treated by the pain score that he has. So the pain score is measured by a scale which ranges from 1 to 10, 10 being the highest. So that's how the pain-free hospital is, the concept of pain-free hospital is. Now, the national presence that we have here in India is, we have worked with NHM, state drug controllers of 25 states and 3 union territories. Training centers that we have catalyzed, 5 training centers, like TIPS is a training center. This demonstration site is a training center. Likewise, we have 4 training centers, and one is MNJ, then GCRI in Ahmedabad, one is in Jaipur, BMCHRC, another one is in Coimbatore, PSG Medical College. So we have catalyzed these training centers. Next is on-site foundation trainings. We have conducted 11 on-site foundation trainings, like the trainings that is happening right now virtually. We do it at your region. Like when a stakeholder approaches us and he or she wants to have a foundation training course in his area, we go there and conduct on-site training, foundation training. That's a 10-day foundation training that happens continuously, 5 days theory and 5 days home care. So we do that. We have done that for 11 sites. We have developed 2 pain-free hospitals. The 2 hearts that you can see in India's map, those are the pain-free hospitals that we have catalyzed, and we are hoping for We are hoping for an India with full of hearts and full green. That's what our aim is, our vision is. We have done faculty development programs at 6 sites till now, and we have catalyzed 72 sites, palliative care centers across India. Hamrahi sites, okay, then Hamrahi is a project where we are working with Australasian Palliative Link International for mentoring palliative care centers across India. As of today, the mentors of APLI have mentored 27 sites through this project. So this is basically a mentor-mentee program. So mentoring the already catalyzed palliative care centers. So as a refresher thing. Hands-on training sites, we have 51 hands-on training sites. Hands-on training sites are you are undergoing a foundation course right now virtually. When it is done on site, you will get a exposure on home care wherever you are doing the course. Now, virtually, you are not able to get what you call hands-on training because you are doing it virtually, and virtually home care can't be done. Home care, outpatient unit, exposure to outpatient, exposure to inpatient unit can't be done. So when this COVID strike, our trainees were unable to get hands-on exposure, and we tried and collaborated with 51 sites across India for palliative care hands-on experience. So after completing your FCPM, if you want to have an hands-on exposure, we believe that merely undergoing theory is not would not help you to do palliative care. You need to have hands-on experience. So for that, we have list of 51 sites which training team will be sharing with you once you have completed your training course. They will share with you based on your the region where you are located. You can see which all sites are nearby to you, and you can go there, have hands-on experience of 5 days, whichever the organization is agreeing to. You can go and have a hands-on experience, and through that will help you understand more about palliative care. So those are already established palliative care centers, which will give you more exposure than theory. So whatever you are learning in theory, you will get to notice in person. Like I already said before, we have facilitated opioid access to 15 sites. This number is after May 2021. May 2021 onwards, we have been counting the numbers. Before that, we didn't even count whom all we have supported with. So after that, we have done 15 sites. So this is the national presence that we have. Thank you for now. Hope I was not boring. Any doubts? Yeah.
We have one query.
I think we have something in our chat box. We'll just go. Okay. How these self-sustained link centers generate revenue to run their service? Like I already mentioned while we were explaining the 10-step approach, first thing that you have to keep in your mind while opening a palliative care center is arranging for funds. So these link centers, which we have catalyzed, they find their fund through micro donations. They create awareness. They go for awareness session. They go for getting public donations. No, none of them are, I think, registered for CSR. They go door to door and gets money and funds. Those are not very established centers. And one more thing, these link centers will have, these link centers will have PHCs and CHCs nearby. So they'll get the medicines that there are medicines which are already available in PHCs and CSCs. So they can go there and get medicines. So for medicines, they don't need to, find funds. Only the salaries for the basic unit that they run, they need to find funds for that. They get sponsors. They don't. I haven't heard any issues on funds for them. So, which two hospitals? Okay. Hope I have answered your query. I think who was that? Dr. Shivani. Hope I have answered your query. Okay. Next question was from Pranjal Gogoi. Sorry, if I misspelled your name, mispronounced your name. Okay, which are the two hospitals under pain-free hospital projects? So the two hospitals that are under pain-free hospital are one is in Dehradun, SRHUCRI, Cancer Research Institute, and Kachar Cancer Hospital, Silchar, Assam. These are the two pain-free hospitals that we have catalyzed. Anything else? If anybody wants to understand more. If anybody has questions, you can raise hand like this also. You're not able to raise hands on your mobile, you can raise hands like that.
But we will see only those who are kept their videos on.
Yeah, ma'am, how Pallium India will help if we want to open a hospice in our city? Dr. Mrinal Dev Chaudhary, you are based out in Guwahati, Assam. You can reach out to Ron Sangma, our regional coordinator who looks into that area. End-to-end facilitation will be done by us, starting from the scratch to opening up a parity care center. So whatever will require any help, we'll start from the scratch and help you. So you can get in touch with Ron. He'll explain you what all support we'll do for you. So we can help you in any ways, every way, in every way. Yeah. Anything specific that you wanted to ask, like, yeah, okay. The hands-on site in West Bengal, where is it situated? Okay. In West Bengal, we have Ruma Vedna Hospice, West Bengal. We have Tata Medical Center, West Bengal. We have Chitranjan National Cancer Care Center and Eastern India Palliative Care, West Bengal. Yeah, okay. If possible, sorry, there is something in chat. This list will be shared with you. So this list will be shared with you. If possible, please send me the Ron's number on my WhatsApp. Sure. The numbers will be shared by training team in the WhatsApp group that you have. No, all the numbers will be shared there. So it was just shared in the chat, but Shri Priya will be sharing it in the group as well.
So presently, I have shared the directory list. Actually, we do maintain a directory in our website, Pallium India's official website, where all the details are given. So I have shared the link for that right now. And regarding the regional contact coordinators numbers, I'm also sharing that as well.
Okay. Certificate course in palliative medicine can be done from hands-on training centers too. No, hands-on training centers are only for hands-on exposure. The training centers that were catalyzed by Palem India, the 5 centers that I have told there, you can either approach them or CCPPM is given by IAPC also, I think. Yeah, IAPC also, Indian provides this CCPM course. Either you can come to Trivandrum, Palem, India. Where are you based out? Vicky Bakshi, Dr. Vicky Bakshi. Where are you based out? Uttarakhand. Okay. Uttarakhand, I think you can approach Jaipur, VMCHRC if you want to do the training, CCPM, or you can come to Parliament. Jaipur is a little nearer to your region. So that's why so yeah, that's why I proposed that. Otherwise, you can come to Trivandrum. We are always welcome.
Even
you are always welcome.
West Africa joining us,
Yeah.
right? We did have participants joining us from West Africa. So Talim India's doors are always
Yeah.
open to you.
And any other doubts? Hope you were able to learn something from this session, and hope some of you are interested to open a palliative care center. So, okay, what's Pallium India's vision is by 2030, we are hoping to touch 10 billion lives. So we will need your help also to attain this this vision. So I'm hoping that you all will be with us for this wonderful vision of Dr. M.R. Rajagopal, our chairman. Yeah, thank you so much, Dr. Indira. We are we're hoping to see you soon.
Any other quick queries or any other questions of interest which we can take in?
Nobody?
I think the presentation was very self-explanatory in itself.
Okay, thank you so much.
In case Giovanni is having anything more to share, I think we can wind up for the day.